Our next speaker was the first physician to highlight the fact that not all progesterones are the same. Accordingly, his information is of vital importance to any woman considering a hormone replacement therapy. Through his ardent research, worldwide lecturing, and publications such as What Your Doctor May Not Tell You About Menopause, he has managed to bring these facts to the attention of medical professionals and the public alike. We're very pleased to have him with us here today. Please welcome Dr. John Lee.
Thank you, Phil. It's a great pleasure to be here, as you might imagine. I'm going to be using this mobile microphone because I'm going to show you some slides by this old-fashioned technique. I readily admit I'm not even at kindergarten stage in some of the electronic inventions that are, and I'm still uncertain that they're really all that good, but I kind of like this way because if I were to go to all the trouble of doing it so wonderfully the first time, I would not like to change, and I find that the rate of change is so great that I'd like to be able to discard them and go on to better things all the time. So that's what I hope I'm going to do. Here, I wanted to start by adding one more thing to the pillars of aging. Humans have the unique situation where the fertility life does not extend to the full life of the females. In almost all other species, they remain fertile throughout life, but in humans, that ability drops out at around age 50. Yet they live another 1/3 of their total lifespan follows that. So we have this great change that happens. In fact, the women call it the change, and we're talking about the menopause. And they see this as a benchmark time of their life. After that, they're no longer able to bear pregnancies. They have hot flushes. They have mood swings. I wrote down a few to remind me. Vaginal dryness. They most likely have fibroids already developed, and their bones are deteriorating. And of course, they see this as a change for the worse. This is a difficult time for women. We have the feminists, on the other hand, saying, nonsense, we are now free. We don't have monthly periods. We don't have to take care of little babies. We're free to do whatever we want, and we still have our full libido, and we plan to use that. But underneath, there is this fear that they reach the peak of their health, and it's downhill from then on. I also have difficulty with the phrase, the pillars of aging. I suspect there's a Freudian implication there that may have been unconscious. Now, I want to say a little thing about this thing about menopause. To conventional medicine, back in the 1950s, when hormones became available, conventional medicine saw this as a great opportunity for new business. They converted menopause into a disease, and the disease was considered to be estrogen deficiency. And the treatment for the disease was to give every woman estrogen. It was felt and it was taught, and I was in medical school in 1950, and it was taught that women are somehow defective, that Mother Nature was not quite square with them, and that they became defective at menopause in that they were deficient in estrogen. None of this happens to be true. This was, I think, an idea perpetuated by the leaders of medicine who were all males and didn't understand what was going on. So not only was it a new opportunity for business, they had a good name for it. They called it hormone replacement therapy. The word therapy is in there regardless of whether the woman is harmed by it or not. And I have on the slide the first and perhaps only death certificate which lists hormone replacement therapy as the cause of death. I put this up to remind you that we're not playing games here. were playing with people's lives. This is a lady named Irene Rankin, and she lived in London. And at age 44, her doctor put her on some estrogen for some minor cause. She did not want to take it. There was a history of breast cancer in her family, and she was afraid of side effects. But he said, oh no, it will prevent Alzheimer's disease. It will prevent heart disease. It will prevent osteoporosis. You need this for living. And she took it, and shortly after developed a pulmonary embolism that, even though she was quickly operated on, she died. And the doctor who filled this out, that the cause of the pulmonary embolism was hormone replacement therapy. Now, if more doctors will do this, then we'll get a handle on just how serious the problem is of hormone replacement therapy. But then he wrote accidental death. Well, that's like saying that every drunk driver is just an accident. But we realize the drunk driver is more likely to have an accident than the sober driver. And so it is that the woman who is on hormone replacement therapy is more likely to have a sudden death like this. It'll be stroke, it'll be an embolus in the lung, heart attack, or the development of cancer. And so these are major factors. A brief history of HRT is that in the first 25 years, it was just estrogen therapy. The women were given estrogen, usually without any measurement of any estrogen level or the level of any other hormone. Any woman who came to the doctor's office with any complaint, and she was over 35, she very likely was told that she was approaching menopause, and the treatment was estrogen. After 25 years, however, it became evident to even the dumbest doctor that the estrogen prescriptions were the cause of the great rise of cancer of the uterus. Cancer of the uterus rose 600%, sixfold. And finally it dawned on conventional medicine that giving the estrogen had a risk. So they also knew that there was plenty of research at that time showing that progesterone, another important hormone made by the ovary, if the progesterone level were normal, cancer of the uterus did not occur. And I remember at that time the New England Journal of Medicine saying, wouldn't it be nice if we had some real progesterone to add to the estrogen therapy? And of course they did, but the typical doctor did not know this, because the pharmaceutical corporations step forward and say, here, we have all these other progestins, called progestogens in the continent, that serve as progesterone, and our research shows that it too protects against cancer of the uterus. And in fact, it did. It also had very many side effects. But the synthetic progestogens were added to estrogen, and then it went from estrogen replacement therapy to a hormone replacement therapy, suggesting it was all the hormones a woman needed, which is another big mistake that was made. But it has taken another 25 years. It seems that it takes a generation for conventional medicine to recognize its errors. Perhaps it means we have to wait until some people just die off so that new voices can be heard. But at any rate, the next 25 years showed that the incidence of breast cancer was rising, and the timing was shortening so that younger women were getting more breast cancer, and that now we know this is due to the estrogen and the synthetic progestogen. So now we have a new dilemma. In the old dilemma of 1976, the downside of estrogen replacement therapy was the endometrial cancer. And I remember then attending conventional medicine events like the California Medical Association special meeting for this, and the solution was to have the patient choose. If she chose to take the hormone replacement therapy and then she got cancer, well, she chose it and she was advised. And if she didn't choose it and got bad bones and had a hip fracture, well, she chose it. So that solved the liability crisis temporarily, but it didn't solve the real problem. I could not believe that Mother Nature could be that cruel to create such a dilemma. And so In 1978, I became aware of all the excellent benefits of real progesterone and started using it in my practice. And so since 1978, I have gathered a tremendous amount of experience, leading to a tremendous review of all the scientific literature, and arrived at the point about 10 years ago to write a small book called Natural Progesterone. And the word natural means that it's natural to humans. It's bioidentical to the hormone that we make. So I want to show you a little bit about progesterone. I don't believe this shows, but in the center is progesterone, a beautiful hormone. As you know, it's made from cholesterol, passes through a temporary stage, pregnenolone, instantaneously changes into progesterone, and not only is it a hormone itself, but it is the one the body uses to make estrogen, testosterone, corticosterone, I can do this, and cortisol, so that it's a remarkable thing that not only is a hormone in itself, but the body uses it as a precursor. And as you know, the body can make these other hormones, but it's much more efficient to do that. Conventional medicine, on the other hand, chose to use medroxyprogesterone acetate and norgestrel. Now, when you look at these, for people who are not biochemists, this is the way they picture the hormones. And you see they all have the basic chassis, but they have different additions to the molecule. And the additions or subtractions are sometimes merely a hydrogen or the addition of a hydroxyl. The tiniest change on that molecule changes the function of the molecule. And in fact, you get opposites. You get estrone, for instance, and testosterone. They have the same basic chassis. Move the hydrogen over here, add a little 2 hydrogens there, and you have testosterone. The idea of just an atom changing the function of the molecule should allow you to be able to think that anything that is not that molecule, say progesterone, any change of that, it will no longer be real progesterone, and that is the case. Medroxyprogesterone acetate has the addition of an acetate and a methyl group, and this, the norgestrel, which is the most common one used in birth control pills, is in fact related to testosterone, and the only difference is the addition of that little ethylene group. So here we have conventional medicine confusing progesterone with these synthetic drugs. And just as an example, the medroxyprogesterone acetate greatly increases your risk of breast cancer and dying of heart disease. And this one, when people use that as a birth control pill and develop hairs on their face that they might have to shave, they go to the doctor, and the doctor said, oh yes, that's the progesterone, not realizing it's not progesterone at all, it's norgestrel. So this is very important. And I will not read all of these, but this is 30 years old, the procreation effects of progesterone, precursor effects, and all these intrinsic effects. And since this first list was drawn up, I could add 30, 40, 50, 60 other things. Just this last month, the month of May, in a review of the PubMed, it's on the internet, all the medical publications for the month of May, there were over 800 studies now involving progesterone. And out of the 800, there were 86 in which progesterone was the main point of the study. This did not happen 5 years ago. This is what's going on now. It's there's a great explosion. And of the progesterone studies, they all indicated benefits of progesterone, differences with the progestogens, and the great advantage of using progesterone over the progestogens, or the great error of using unopposed estrogen. It's beautiful to see the change. Now every intelligent doctor that I know admits that unopposed estrogen is an error. Almost every intelligent doctor I've met knows now that Provera is not progesterone. So we're making a great advance. But when I compare the progesterone effects with the estrogen effects, you will see that for everything that progesterone does that is beneficial, estrogen does the opposite. This doesn't mean that estrogen per se is bad. It means that these two hormones work like yin and yang. They work like the Tao. There has to be this interplay between the two to create the effect that is ideal for the body. So just as estrogen increases body fat, progesterone helps to use the fat for energy. Just as estrogen increases salt and fluid retention, progesterone is a natural diuretic and protects that. Goes on and on. This last month, they showed that progesterone is what keeps the sphincter of Oddi fully open so that you get a good flow of bile and a good flow of the pancreatic enzymes. Estrogen, on the other hand, causes it to go shut. This is why estrogen dominance, as I call it, leads to gallbladder disease and to indigestion. And there are more effects on sleep. A real progesterone helps the sleep to be deeper and better, and the synthetic progestins prevent that. And estrogen, in fact, can create panic reactions at night if it's unopposed. So from this, I evolved the notion of estrogen dominance. If there is a difference between these two, and they operate that way, it's wise to know where it comes from, because it leads to aging. Estrogen dominance, just as mentioned in the first list, estrogen and cortisol and glucose, estrogen dominance leads to aging. And we have it from the diets, the sugar and the refined starches, all lead to estrogen dominance. Phytoestrogens prevent any excessive intake of food, and impaired liver function. When I was in medical school, we used to think that impaired liver function meant that the person was an alcoholic and had cirrhosis. And now when I see impaired liver function, I think this woman has been in the hands of a doctor who gave her Prozac, because Prozac binds up the 450 system and in the liver and prevents the sex hormones from being excreted. So by impaired liver function, you must realize the usual meaning of that is due to drugs that your doctor is giving you. The business of cirrhosis can happen, but it is very, very rare. Winston Churchill drank an awful lot, but he also ate very well, and when he died, he had no sign of cirrhosis. So it's not the alcohol per se, but there's a lot of impaired liver function. Then we have stress and the environment. The environment is full of things now that we call xenoestrogens, the result of the biochemical or the petrochemical age. We have well over 60 or 70,000 drugs made from petrochemicals that are in the environment that all act as potential xenoestrogens. Xenoestrogens means foreign estrogens. They have a disastrous effect on the development of the sex organs in the embryos of animals. It happens to birds, turtles, frogs, fish, alligators, the Florida puma, and to children around the world. They're being born with damage to their gonads. In the girls, it's the ovaries, and the follicles have been damaged, so they run out of the ability to make eggs and to make progesterone by the time they're 35 or earlier. In Western Europe and in Canada and the United States, 50% of the women by age 35 have lost that function of their ovaries. They continue to make estrogen, but they're not making progesterone. Something brand new in the history of man or woman. And they're also found in our food chain and in plastics and so on. If the baby happens to be a male baby, it damages the sperm, so that the sperm production, so that by age 40, a typical man in Western Europe, Canada, and the United States, the industrialized countries, typical man at age 40 produces only half the sperm that his father did. So it's a disaster that's going on. Stress, we now know that cortisol, and in fact, this last May, there were several articles showing that even temporary stress that activates some adrenaline also stops progesterone production, it makes estrogen dominance, and you do get anovulatory cycles occurring in women. The work of Dr. Pryor in Canada, and she found that in those women, they don't make progesterone, but they continue to make estrogen, and by age 35, their osteoporosis has already started. Osteoporosis is not a disease of estrogen deficiency. It's not a disease of calcium deficiency. It's a disease of progesterone and testosterone deficiency. And it all has to do with balance. And the big one is iatrogenic, or doctor-caused. He is out there giving birth control pills and HRT, and he is creating estrogen dominance in every one of these patients. Fortunately, the patients are more intelligent than the doctor, and for every 100 women being given these pills, 85% of them discontinue them within 5 years, so that they find that there are side effects, they see bad things happening to their friends, and therefore, fortunately, they give up, but there is damage. The women are told, however, that they must take it to prevent heart disease. And there has been no study until this one that showed whether or not estrogen or HRT actually prevented heart disease or heart attacks, or whether it may have caused them or had no effect. And this study was actually funded by the permanent folks, and the results are very simple. After 5 years of observation of treated women versus untreated women on placebo, you'll see that the dark line and the dotted line are essentially identical, and this is the one and only study that actually compared heart attacks as an endpoint. Prior to that, they used surrogate endpoints like a 5-point change in cholesterol or fibrinogen or something like that, which is all nonsense. When you actually look at the heart attacks, you find there's no benefit from HRT whatsoever. And in fact, women don't die from heart disease the same way men do. They do not have their coronaries filled with cholesterol junk. They die with their arteries open, and still they die of enough heart attacks so that the ultimate heart death incidence in women matches that of men, which is a surprise to most people. Most of us think of heart attacks as being in men, and in fact the ultimate level in men is the same as in women. However, when they die, their coronary arteries are open, and there should be no reason for this death, except doctors in Oregon, at the University of Oregon, thought that perhaps it had something to do with coronary spasm, that the coronary arteries tighten up, and when they tighten up to the point of blocking the flow of blood to the heart muscle, then the women die. And the only other animal that does this degree of spasm happens to be the monkey. In this case, the rhesus monkey. And you see the animal chosen by conventional medicine is the pig. And the pig's heart coronary arteries do not do this. In our arteries, we will tighten up if we get a letter from the Internal Revenue Service. We'll tighten up our arteries if someone says something bad about our favorite daughter. We'll get a spasm of our arteries if we go out and see our car has been bumped into. And the monkeys are also sensitive that way, and they need it because they fly through the jungle hanging on by their tails and their arms, and they need to be able to shuttle the blood through the right set of arteries. And they also have emotional responses that do the same thing, so they chose the monkey. In the pig's case, the pig doesn't care. So you would never find the cause of heart attacks in women by looking at pigs. In this study, they learned how to do angiograms, and these represent angiograms. If this represents a heart, and this represents a heart, these are the coronary arteries filled with a dye. The lower level is the rhesus monkeys who have been made menopausal by removing their ovaries, and the coronary arteries were filled with dye. The monkeys were placed on HRT with Provera, and this is an angiogram, shows a normal coronary artery. They then did a dilation effect to make sure that it wasn't in spasm. Then they gave a spasm medicine derived from platelets of the monkey, prostacyclin A, or prostacyclin B it was, and that caused the spasm to develop. And you'll see that the flow of dye through the coronary artery is blocked off, and the monkey would die within 10 minutes if nothing were done. But they then gave dilating medicine, and they were able to restore some flow of blood and keep the monkey from dying. So the typical male treatment of reaming out your coronary arteries would have nothing to do with the problem of a woman's heart attack. And the top one, you'll see that another angiogram. It went through dilation, the spasm medicine was given, and nothing happened. The monkey was fine, no change. And then the unthinkable, they gave a triple dose of spasm medicine, which would have killed most monkeys, But if they were on real progesterone, as these monkeys were, they had no spasm that would kill them. So this sort of test has been repeated 6 times. It's now over 5 or 6 years old. The authors have been to the American Academy of Cardiology. This is what happened when estrogen was given. The hyperplasia of the cells doubled, and when progesterone was given, it reduced it to about less than a fourth of what it was, and the combination showed that progesterone maintained it at the normal level. And this is, instead of merely counting the doubling cells, they use pCNA, which is a protein left over after the division of each cell, and it's considered more accurate, and you'll see the reduction by progesterone and the great increase by estrogen. And the funny thing was that when they looked in the serum, they couldn't find any of the progesterone. That's a Chang study you just saw. Progesterone applied topically, it readily penetrates the skin. It increases the tissue progesterone 100-fold. It introduced a biological response. It lowered the proliferation rate of breast ductal cells where cancer starts. And it did not increase serum progesterone level. And this is very important. The real hormone is fat soluble, and it rides around on red blood cell membranes and other sources of fat in the blood, and it does not ride in the serum, which is the watery, non-cellular part of the blood. So for the last 50 years, conventional medicine has been looking in the wrong part of the blood. Dr. Cummings at Harvard evaluated this situation and came to the conclusion that serum tests of hormones, sex hormones, are totally irrelevant. Not just fuzzy, not just we have to take them with a grain of salt, but totally irrelevant. The only accurate measurement of the free is the free hormone, which is not protein bound. When these hormones are made, they circulate in the bloodstream, they go through the liver, they pick up a protein binding. The protein binding makes them water soluble, so when they go through the kidney, they'll be excreted in the urine. Once they are protein bound, they are no longer biologically active, or they're greatly inhibited in their binding to the receptors in cells. So the only active hormone is the free hormone, and the free hormone is determined very easily by saliva. When the blood goes through the saliva glands, the free hormone is readily dissolved into saliva, and it's a very accurate reading, and this is the proper way, and scientists have known this for now 20 to 30 years. And so all of the theories and assumptions based on serum testing turn out to be erroneous. Now, this is Dr. Moore in England. At the same time, I became interested in progesterone and began using it for women who needed it for osteoporosis. They were women who had a history of cancer, breast cancer, endometrial cancer, and I can say to you that after 20 years, there's no record I have, no knowledge that any of these women ever died of a recurrence of their cancer. Progesterone is remarkably effective in that way, and Dr. Moore in London went to the top 3 hospitals in 1978, asked them to follow take some blood from women who are having breast cancer surgery and to put the blood in the refrigerator. And granted this is blood, he separated them from being those that had a normal range and those that were essentially absent, which isn't bad. And he followed them for 28 years, and you will see that their survival. These were women with node-positive disease, the worst possible case. They already had breast cancer with metastases at the time of surgery. If their progesterone on the day of surgery was good, they had a 66% survival 18 years later. If the progesterone was low on the day of surgery, they had an only 35% survival rate. The presence of progesterone on the day of surgery doubled the survival rate. There is no treatment for metastatic breast cancer which comes close to this benefit. And yet, it was standard. If Dr. Moore had followed these women through the 28 years and added progesterone when their own progesterone fell, he would have raised this curve higher and higher and higher, as it was in my patients. So the evidence, there are now 12 studies like that that all show that. The evidence culminated 3 years ago in March, when Dr. Cavalieri presented a paper at a special meeting that was scheduled by the National Cancer Institute in Washington, D.C. They invited the top 25 cancer research centers in the world to submit their data, what they know about estrogen, particularly estradiol and breast cancer, and estradiol and prostate cancer. And Dr. Cavalieri was the head of the cancer research at the University of Nebraska for 25 years, and he had finally evolved all the steps to show that with regular estrogen, estradiol and estrone, but not estriol, it follows through the liver. The P450 adds a hydroxyl group, it's called a catechol, and then it becomes methylated, and then from then on it is safe. If the woman is still eating margarine and trans fatty acids, it will often pass into another pathway, and a quinone is added, and then if she's not eating garlic and onions and beans and things that have sulfur-containing amino acids, they will bind to a DNA, create a mutation, and lead to cancer. And this is true of both breast cancer and prostate cancer. Dr. Cavalieri sent me this, is his representation, so you can see every step along the way. And it was published in the Proceedings of the National Academy of Science. And finally, from that, this is another way that it's presented. The 4-catechol estrogen undergoes a glutathione transferase, can be conjugated out, but it can also be an adduct to the DNA, leading to mutations and to cancer. So Dr. Cavalieri was so certain that this would change the course of history. He called me and said I really should be there, and I couldn't, but I got some other doctors to go. And they were so enthusiastic about it, they said, the news will get out now, because the radio was there, the television people were there, the press was there, and 25 reporters from around the world, from Karolinska, Sweden, to the Mayo Clinic, they all had found that estrogen is a cause of breast cancer and prostate cancer, and probably the main cause, and yet not one word of this ever reached the press. It was nowhere in the newspapers, nowhere in the radio or the television, nowhere. It's not even in medical books, but you can get it from the National Academy of Sciences, the National Cancer Institute. It costs, I think, $50 American for all 25 papers. Conclusion is, hormone replacement therapy and breast cancer risk, if you use synthetic progestins, such as Provera, combined with any of the estrogens except estriol, such as Premarin or estradiol, you will increase the breast cancer risk 1.4 to 2-fold. In the case of the Provera, it increases the risk of breast cancer by 8% per year of use, which means that in 5 years of use, you will increase your risk of breast cancer by 40%. Can you imagine? If this were to come up as a new drug, and it were found to increase breast cancer by 40% in 5 years, would it have a chance in hell of being acceptable to anybody? Not only that, the estrogen part increases the risk of stroke by 300%. There are 3 times more strokes than in people on estrogen than in people who are not on estrogen. I want you to understand a little bit more about how to measure progesterone levels. Seems that the biggest hang-up, there are 2 big hang-ups in the conventional medicine using real progesterone. One is, they say, until they show me that it prevents endometrial cancer, I won't use it. Well, that's now been passed. That problem is passed. It has been shown. The Green Journal in the United States, it's called the Green Journal, this month, the June issue, it's the Journal of Obstetrics and Gynecology, is honoring by publishing the paper of Dr. Helene Leonetti, just completed. It's a 3-year study of the effect of progesterone on estrogen-induced hyperplasia in the uterus of healthy women. They took postmenopausal women, put them on Premarin, did biopsies of the uterus to show that, yes, all of these cells were now multiplying. You had hyperplasia developing. Then they gave some of the women a modest physiological dose of progesterone as a cream, 12 to 15 milligrams a day. And they did biopsies down the line at 3 months and so on. They had other women on Provera. They followed them with biopsies. They had some women on placebo. They followed them with biopsies. The conclusion was that in those women treated with physiological doses of real progesterone, transdermally given, had no hyperplasia, no abnormal cells, nothing going wrong, a perfectly healthy endometrium at the end of all this time. And the question is now answered. Normal physiological doses of progesterone given transdermally does protect against cancer of the uterus. It just has never, there's never been a case of a woman with normal progesterone levels who ever developed cancer of the uterus. So that part is cleared. And the second part, that they'll say that they don't know how to measure it. They've tried with the blood test, and they've given progesterone to women, and they find no change at all in the serum. And they just can't figure that out. One company here in Europe is making a transdermal progesterone cream that's used as a vaginal cream. They were able to patent the cream part. It's a gel, actually. They made a special bioadhesive gel, and they use it vaginally. And they showed that it offers perfect protection against cancer of the uterus. So they are advertising that fact. They, however, also measured the progesterone in the serum and found no change, even though they found that the women's fibrocystic breasts all cleared up and that she slept better. Obviously, the progesterone was going through the body, but they couldn't find it in the serum. So they came up with a new mechanism. They said it somehow gets to the uterus where it does its wonderful thing in protecting against uterine cancer, and then it disappears. Wow. First pass loss through the uterus. And they're looking in the wrong place in the blood. So 20, 30 years ago, people found that these are very fat-loving molecules. They bind they ride with fatty substances in the blood. And the major fatty substance in the blood happens to be the membrane of red blood cells. So these hormones ride on the red blood cells. Only a small amount of them are actually free in the serum. Most of them have passed through the liver and acquired a protein binder, and that is going to carry them out to the kidney. So if a doctor uses just serum, he will get a large amount of the protein-bound hormone and a tiny amount of the free hormone that still hasn't been bound or used up somehow. And that's what he will get. And he will not be able to tell how much of it was protein-bound and how much was free. This is why Dr. Cummings called it of no value whatsoever. And on the other hand, if a doctor is wise, he will learn to measure saliva, because the free will dissolve into saliva regardless of whether it's on red blood cells or still in the serum. So this test automatically separates the free hormone from the protein-bound. Even the urinary progesterone level is of no value, because you never know how much of it is free in the blood at any one time. So this, by the way, I think will be in our new book. We have a new book coming out, our 5th, called What Your Doctor May Not Tell You About Breast Cancer. It's scheduled for release in January. Dr. Zava is the lead author of this. He has been studying this for 25 years, has thousands and thousands of women as a database, and we've come to the conclusion that 80% of the breast cancer that occurs in the United States and Canada and probably Western Europe is due directly to estrogen dominance. For instance, in a study of 3,000 biopsies from women who had breast cancer, compared to several hundred biopsies of women who did not have breast cancer, he found that 2,999 of them had estrogen dominance. Their tissue in the breast had high estrogen and low progesterone levels. You see, the absolute numbers are not important here. It's the balance that's important. And we now know what the balance is that divides the healthy breast from the precancerous, the one that's going to become cancerous. In the one out of the 3,000 that had breast cancer that had good progesterone, that lady had a very rare condition, a genetic condition, in that her cells could not make progesterone receptors. So when you don't have a progesterone receptor, it's the same as if you have no progesterone floating around at all, because these hormones only work by binding to its receptors in the cells. The cells have to anticipate the arrival of the progesterone molecule. The progesterone receptor, in fact, is driven into production by the presence of estrogen. So the two hormones balance each other. But this woman could not make any progesterone receptors. So at 16, she got her breast cancer and died within 6 months, regardless of what treatment is given, because you cannot succeed unless you can restore the progesterone effect. And so it was 3,000 out of 3,000 shows that it was progesterone. So this is what Dr. Zava did. He showed that if the steroid hormone is in the red blood cell, or if the steroid hormone is in the serum, both of them get into the saliva, whereas the protein-bound never gets into the saliva. So that is his picture that will appear. But this would indicate that you could do saliva tests for endogenous hormone at any time, because every 50, 60 minutes there's a new pulse of hormone, so it never gets a chance to fall very far before the next pulse of the hormone is generated. However, when a woman is receiving progesterone from a pill or a patch, she is receiving a huge surge of progesterone at once, and the pharmacokinetics are different. She is absent in her progesterone prior to receiving the dose. These are women who were given just 20 milligrams of progesterone as one dose in the morning at 8:30. And by 10 to 10:30, she has this very high surge of progesterone, and it begins to fall off because as it passes through the liver, it begins to get bound to protein, and it is going to be excreted, or it is changed into 3 or 4 different pregnanolones and pregnanolines, one of which is quite valuable, allopregnanolone, quite valuable because it tends to be a calmer downer. It's anxiety. They call it anxiolytic. It tends to lyse anxiety. So for people who have PMS, for example, this is a very good side effect to have. But at any rate, the hormone is rapidly removed from the body. The average half-life of the progesterone molecule, once it's released in the bloodstream, is about 5 minutes. So every 5 minutes, there's half of it being gone. And so it drops down. So by 10 hours later, you've lost 95% of the progesterone. These are the serum levels. There is no significant change whatsoever, and these are the saliva levels. Studying this chart, and the many like that, you realize it would be wiser to give smaller doses twice a day than a big dose once a day. So we learn now that if we were to give half doses twice a day, we can even out this surge. But this works very well. The typical production of progesterone in normal healthy women is 15 to 20 milligrams a day. So when women are found to be making estrogen and not making progesterone, what you need is 15 or 20 milligrams. But it would be wiser to give it as 10 milligrams twice a day through the skin, and then you will have a much more even one. People often ask me about some of the synthetic hormones that are being advertised as SERMs, selective estrogen modulators and receptor modulators. And this is one that is now the #1 seller in the United States. It's raloxifene. It's known as Evista. They advertise in the literature, in the AMA journal, showing this 55% reduction of cavities. But you have to read the fine print. It says 55 significantly reduces fracture in first-time vertebral fractures. First-time vertebral fractures are little tiny microscopic fractures that all people have. When you're 15 years old, you might be 5'8". When you're 60 years old, you might be 5'7". You've lost an inch over all these years. Maybe 20 years later, you might have lost another ½ inch. Those are the little microscopic compression fractures that occur in your spine. They never put anybody in the hospital. You're totally unaware of them. It's totally of no consequence in a clinical sense whatsoever. What's important is hip fractures, leg fractures, arm fractures when people fall down. So there is one study, and one study only, of this hormone, and it was published in the AMA journal. And it shows in hip fractures, after 36 months, there's no difference between the placebo and the drug. And this is a combination of all the osteoporotic non-vertebral fractures for three years, 36 months. And you can see there is no significant difference whatsoever, no clinical difference whatsoever. Then when you read this fine print, you see that it says there is a probable adverse event that can happen. It's an increased risk of VTEs. V is in Victor, T is in Tom, E is in Easter. And the greatest risk occurs the first 4 months. And they count on the doctor not reading the tiny print in back. You can see this gray on this page is the tiny print. You need a microscope to read it. You find that VTEs refer to embolic thrombi that can cause strokes in your brain or a big blood clot in your lung, which is usually lethal. It increased the risk by 300%. So doctors are giving this Evista as the #1 replacement now for osteoporosis, for women who need estrogen. They don't want to give the estrogens that the women are accustomed to because they all are fearful of them. They're using this instead. It did nothing for hot flushes. It did nothing for anything else in the body. There was no benefit from this drug whatsoever, and it did not help reduce any fractures, and what it did do is increase the risk of stroke by 300%. So people wonder, how in the world do these things happen? And what they don't realize is that in the age we live in, pharmaceutical companies can control patient demand. They can advertise their drugs in such a way that the patient will demand them. The sales of patent medicine, prescription drugs, is driven not by doctors' education anymore, it's driven by patient demand. Here is a beautiful example. This occurred just last month. Breast cancer drug proves a lifesaver was in all the newspapers, and it was on the radio and the TV, and in the paper, doctors were quoted as saying the effect was a miracle. It was fantastic. One of the patients said it was double miraculous, whatever that means. And when I read in the New England Journal of Medicine what the doctors wrote about it, they said this new drug increases the clinical benefit of first-line chemotherapy in women with metastatic breast cancer that overexpress HER2, which is a gene-caused breast cancer. So this is the only graph in that study, and this shows the new drug was supposed to go along with conventional chemotherapy, and they had 235 women, and 40 months later, all but 11 had died. In the chemotherapy without the new wonder drug, they had 234 women, and 40 months later, there were 13. Would anybody here in this room be impressed by this wonderful new miraculous addition to chemotherapy? It does nothing. But the demand that was created goes to the doctor's offices from the public because of the ads that happen. And see, people presume that if it's in the paper, it must be true. They do not know that the pharmaceutical companies merely give the science editor of the paper or the TV station something he can easily slip into the news without having to do any study of it whatsoever. It comes all ready to go, and it gets in. But I do not regard that as a great improvement. It might extend life a week or two at most, somewhere along the way, but the net result is no difference. So the problem that I think most of you in the room are fighting is that the pharmaceutical companies have a great advantage in having their stuff almost instantly published in the press, and it creates the consumer demand. I brought one more thing to show you. The last New England Journal of Medicine I got before, the last one I got before getting on the plane a week ago to read, it had a major article about estrogen and thyroid. Now there's a lesson to be learned in this. 30 years ago, we had learned that if you give estrogen to women, something happens to the thyroid hormone that it's inhibited in its action. It doesn't stop the thyroid gland from making the hormone, it stops the thyroid hormone from doing its work. And this was in books in the early 1970s. The new article finds the same thing. Only the doctors now were able to find that the reason that estrogen causes the thyroid hormone to not work as well, and therefore cause symptoms that are identical to hypothyroidism, is that estrogen not only induces the liver to make a protein that binds the estrogen, it induces the liver to make a protein that binds the thyroid hormone. So, if you give a woman thyroid and say you give more than you need, or more than Mother Nature intended, it will trigger the release of these proteins that will bind the thyroid hormone out in the cells in the blood so that it cannot work, and it will create what appears to the doctor to be hypothyroidism. Now, when I discover something like this, I say, that's a sign of excess estrogen. Let's back down on the estrogen. And Dr. Cummings, the same doctor at Harvard that's been doing all these wonderful studies, he finds that the amount of estrogen given by conventional medicine is 8 to 10 times higher than physiological need. Guess what we have in the United States and Western Europe and Canada now? We have an epidemic of people showing up in doctors' offices with hypothyroidism. The doctor will do the tests, and he will find that the T3 and T4 are normal. There's a normal amount of thyroid circulating around the blood. What he doesn't know is that half of it is bound up to protein. But he senses that the woman has hypothyroidism. So he says, well, I'm an MD, minor deity. I can override the laboratory results, and I'm going to prescribe more thyroid. Well, when that happens, you create a dissonance in the cells of the thyroid. They are making enough, and now comes more thyroid than the body actually wanted to make, and the end result of this is autoimmune disorders, and you get Hashimoto's thyroiditis. And she doesn't need more thyroid, she needs to reduce the estrogen. However, the wonderful doctors and the editorialists who wrote about this, who figured out the mechanics of this, that we now know how this comes about, their conclusion was that if you meet a woman who is hypothyroid on being given the estrogen, you should give them more thyroid. Oh, so close to enlightenment, right? And this is what happens all the time. Now, when I get home, I'll write a letter, and I'll say, one could argue, with perfect safety, that what they should do is quit giving the high doses of the estrogen. This is another way the body's saying that estrogen has these toxic effects. So in conclusion, what I have been trying to lay out is that menopause, which is a natural occurrence in the life of humans, and it does occur in men too, but not in such dramatic fashion. Men can manage to deny its existence for a longer period of time because it's not a dramatic thing, but it does happen to men. And I will say now that we have excellent evidence that men's prostate cancer is caused by the same identical mechanism that cause endometrial cancer, that cause ovarian cancer, that causes breast cancer. When you arrive at the point of estrogen dominance, you will be turning on gene BCL2. Gene BCL2 tends to cancel the planned suicide of cells as they should be occurring, and the apoptosis of cells. Without the apoptosis of cells, the new cells coming along have no place, no reason to exist. But BCL2 is a known cancer-causing gene. It's called an oncogene, and it is activated by estrogen. Estrone, estradiol. Estriol does not. And progesterone and testosterone, on the other hand, activate a protective gene, P53. P53 blocks BCL2, tells the cells to commit normal apoptosis and do not become cancer cells. This is the same mechanism in all three tissues, and it shouldn't be a surprise because the prostate is the male equivalent from the same embryonic cells as was the uterus in the female embryo. So they have the same background, they have the same cells. But at any rate, we believe that the development of these cancers, the development of the aging that occurs, is not the result of merely the passage of years. We think it's the result of a misuse of these drugs and a undesirable ratio that can be corrected by proper administration of HRT. Now, I don't want you to think that progesterone is the panacea for all these things. We know that there are things that have to do, in fact, I wrote down a little list to remind myself of things that doctors should not forget. For instance, progesterone is what stimulates the osteoblast to make new cells in bone, to make more bone. However, without magnesium, you can't do that. So even though the hormone is there telling the cell to do that, it needs the magnesium. And of course, vitamin C and other things too. So all these things are important. Genetics is important. Someday they'll be able to correct that. Diet is important, particularly the diet that leads to insulin resistance. Insulin resistance is the new buzzword in medicine today. It is the point in our metabolic understanding that separates good things from happening from bad things that are going to happen. Exercise is important. Stress management. Oftentimes you can't avoid the stress. That would be ideal, but you can learn how to manage it. And the essential fatty acids. I am particularly impressed with Mary S. Enig, PhD, professor at the University of Maryland. Here in England and I think in the Western Europe, when foods are sold, there is a nutrition listing which will tell how much of it is the trans fatty acids. And you probably all know the trans fatty acids are abnormal malformations of real fats and acids, fatty acids from plants, for instance, and from waste animal fats, that is sold as being good fat, and in fact is bad fat. And then we have special nutrients that modulate metabolic function. We have the xenoestrogens that we have to learn how to live without. We have to learn about the phytoestrogens, which are the #1 estrogens sold in France, for instance, the antioxidants, cytokinase, testosterone, cortisol, and all these things. So it's a small chore that you all have to learn all these. What I'm trying to contribute is the knowledge I've learned from my patients over the years and the research I've done and all of the literature reading about the role of progesterone. That's what I'm trying to to help to get that across, because this has been neglected by conventional medicine for 60 years. They are enthralled by the synthetic progestogens because they can be patented and they make a lot of money. And in fact, the money made by the sales of HRT hormones is greater, it's a greater profit than any other prescription drug sold. And it's been that way for 30 years, and they do not want to lose it. That's why they hate me. But it's up to you to see that we make these changes and use HRT wisely. Use HRT in the sense of normal physiological doses, and use the estrogens and the progesterone that are normal and natural to humans. Same thing with insulin, same thing with thyroid, same thing with everything. There's no reason to resort to synthetic lookalikes. Thank you very much.